cardiac arrhythmia is our topic of discussion for this video. In the later part, we will also talk about especially heart blocks. Heart blocks are also known as junctional blocks or nodal blocks. So these heart blocks or junctional blocks are also some types of cardiac arrhythmia. So cardiac arrhythmia is a broad term, and under this heading we'll learn about heart block and many different topics. We'll delve into this, but before that let me tell you, you all know about 1 beat is equal to 1 cardiac cycle, right? I mean, into the 1 beat we have systole plus diastole, and when we talk about systole, it implies atrial systole as well as ventricular systole, and also when we talk about diastole, it implies ventricular diastole and atrial diastole, and these 4 events combine to form a single beat. And we know that in a normal person, for in a minute 60 to 100 beats, I mean heartbeats should be there. SA node creates the beat. SA node is situated in the right atrium, and SA node creates the beat through this process of cardiac cycle, and these beats ranges from 60 to 100 beats per minute in a normal person. If irregular beats are formed, or simply we say irregular rhythm is formed. What is rhythm? What is normal rhythm? We will talk about it. But if we try to define what is cardiac arrhythmia, then we can say irregular heartbeat or disturbance in the rhythm of the heart are referred as cardiac arrhythmia. So in arrhythmia, heartbeat may be fast, may be slow, and there are many things that are written here, but let me tell you simply that exactly what is cardiac arrhythmia. You need to know that what is normal rhythm of heart. Remember that if you want to tell normal rhythm, then the heartbeat should ranges from 60 to 100 beats per minute in a person, beats per minute. Average which is 72 beats per minute. If this occurs, we can call it normal rhythm. No. SA node should be the pacemaker. Should be the pacemaker means SA node should generate the impulses. Okay. If heartbeat is within 60 to 100 beats per minute and SA node is the pacemaker, even then we cannot call it normal rhythm. The conduction pathway, we know the conduction pathway, right? From in the heart we know that if it is right atrium, it is right ventricle, it is left atrium, it is left ventricle, and here is the SA node. So SA node starts the impulses, generate the impulses, it has automaticity, so it starts the impulses and it depolarizes the whole heart one and one. So SA node starts the impulses, from the SA node it goes to the AV node, and AV node transmitted to the right and left bundle branches. From the right and left bundle branches it goes to the purkinje fibers and it depolarizes the ventricles. So this is how it goes, right? So the normal conduction pathway should be maintained. I mean, from SA node it is not going to be able to AV node, then it is not normal. Normal conduction velocity should be there. I mean, we know that the conduction velocity in the SA node is medium, AV node the conduction velocity is really less, and when it goes to the purkinje fiber it is really fast. So the normal conduction velocity should be there. If these 4 conditions are fulfilled simultaneously, at that time we can call it normal rhythm. If one of these requirements is not fulfilled, we cannot call it normal rhythm. So when abnormal rhythm occurs, I mean the breakdown of any of these 4 requirements occur, we call it arrhythmia. So this is a very important point to remember, that if one of these things occur, disturbance of one of these things, we call it cardiac arrhythmia. We can classify it into normotropic arrhythmia and ectopic arrhythmia. Look, when SA node is the pacemaker, we call it normotropic arrhythmia. I mean, SA node is the pacemaker, okay, that's fine. Number 2 point is fulfilled, but rest of the 3 points are still in a fix. Right? There might be abnormalities in one of these 3 points. No, point 1 that we discussed earlier, point 3 or point 4. I mean, the heartbeat may not be normal. 3 number points, the conduction velocity may not be normal, or the conduction pathway may not be normal, but the SA node is the pacemaker. That time we call it normotopic arrhythmia. And when ectopic arrhythmia occurs, it means that SA node is no longer the normal pacemaker. Okay. So first discuss about normotopic arrhythmia. In normotopic arrhythmia, SA node is the pacemaker. I talked about it earlier, and there may be 3 types: sinus arrhythmia, sinus tachycardia, sinus bradycardia. Let me tell you, the sinus arrhythmia means we told that during inspiration, we know that parasympathetic system works by vagus nerve. So when vagus nerve is itself inhibited, that time what occurs? That in SA node, it cannot gives any impulse. I mean, it cannot give inhibited impulse, or it cannot control SA node. So SA node may fire up, and it may cause heartbeat to be more and more. So that may cause tachycardia. So during inspiration, what happens? Heartbeat increases and tachycardia occurs. Okay. And during expiration, or we can say exhalation, this is called expiration, right? This is called inspiration. And during expiration, heartbeat decreases, and this causes bradycardia. So all together, this tachycardia during inspiration and bradycardia during expiration combinedly called sinus arrhythmia. So look into the slides. Sinus arrhythmia is a normal rhythmic increase and decrease of heart rate in relation to respiration, and it is increasing during inspiration and decreasing during expiration. Normal heart rate is 72 beats per minute. Under physiological conditions, in a normal healthy person, it may vary in the respiratory phases. Okay, so it's physiological. Okay, it's not abnormal, we can say, and it is mostly observed during deep expiration and inspiration. We observe this sinus arrhythmia. Okay, then we are going to talk about sinus tachycardia. Okay, so sinus tachycardia is nothing but the normal tachycardia we talked about. When heartbeat is more than 100 beats per minute, we called it tachycardia. Okay, so basically the SA node fires up, and it may be due to many physiological and pathological conditions. We told earlier in the video of heartbeat that during exercise, when we are having exercise, that time we may have tachycardia, right? And in many pathological condition like fever, hyperthyroidism, hypoxia, in many pathological condition also, tachycardia may occur. So whatever happens, it may be physiological, pathological. If heartbeat is within 100 to 150 beats per minute, we normally call it sinus tachycardia. Why sinus? Because it is by the discharge of SA node, right? So when SA node is involved, as SA node is the pacemaker here also, and SA node is creating the high heartbeats, or we can say too many heartbeats. So this is why it is called sinus and tachycardia, normal tachycardia. We may also call it tachyarrhythmia. Okay, both are same term. And sinus bradycardia when heartbeat is less than 60 beats per minute. And also there are some physiological and pathological causes of bradyarrhythmia or sinus bradycardia. We learned it earlier, so go to the heart rate video of mine in the playlist, or you can search heart rate Sakib Rahman. That in that video you will find it that why sinus bradycardia, that what are the causes of sinus bradycardia. Okay, now ectopic arrhythmia, when SA node is not the pacemaker, I mean impulse produced by other structures which may call ectopic foci. So it is very important to note. And ectopic arrhythmia may be of different types: heart block, extrasystole, paroxysmal tachycardia, atrial flutter, atrial fibrillation, ventricular fibrillation. Okay, heart block is important for written and viva exam, so we will talk about it a bit later. Now we are talking about these things. Extrasystole. Extra means something which is extra, right? So before normal contraction, we know that heart will contract, ventricle will contract. Before normal contraction, a premature contraction occur. Premature, I mean extra contraction occur. And this is called extrasystole, okay? So what is extrasystole? A premature contraction of heart before normal contraction. So it may be due to many causes like very much excitation or exhaustion, very much disturbed and exhausted. So that time it may occur. So it may occur in very physiological and pathological condition. But what is extrasystole? Premature contraction of heart. Normal contraction will occur, but before that premature contraction is occurring, right? So that is causing extrasystole. What is paroxysmal tachycardia? We came to know that 100 to 150 implies the sinus tachycardia, and if the heart rate is 150 to 200 250, we may call it paroxysmal tachycardia. Okay, so paroxysmal means what the term paroxysmal means sudden appearance and sudden disappearance. I mean, it is coming very fast and it is going away also fast. So we observe that 150 to 250 heartbeat, when it occurs, it is occurring very fast and it is also disappearing very fast. So this is why the paroxysmal term has come into action. And atrial flutter, when the heart rate is 250 to 350 beats per minute, we call it atrial flutter, okay? And when the heart rate is more than 350, I mean heart rate is become 250, the stroke volume has decreased too much, but before ventricular filling the heart is contracting, so the heart rate has become so much and it has become more than 350. At that time we call it atrial fibrillation. And when it occurs in atria, I mean when atria contacts more than 350 times per minute, we call it atrial fibrillation. When ventricular contacts more than 350 times, we call it ventricular fibrillation. So based on the location of contraction, we may differentiate it into ventricular or atrial fibrillation. And atrial fibrillation or ventricular fibrillation, these are very dangerous condition. Heart block means blockage of impulses generated by SA node in the conducting system. So normal transmission of impulses, we know, for example, it is right atrium, it is left atrium, it is right ventricle, it is left atrium, it is left ventricle. So SA node is located here, and from SA node the depolarization goes to the AV node, and AV node is located here. So AV node from SA node after generation of impulses, it is not being able to come to the AV node. So here is the blockage. So this is called sinoatrial block. When generation of impulses or transmission of impulses from SA node to the AV node is hampered, is blocked, that time we call it sinoatrial block. And when from the AV node it is not being able to transmit to the ventricles, from AV node is not being able to transmit to the ventricles, and we know from the AV node it goes to the ventricles. So from when problem is in the AV node, that time we call it atrioventricular block. I mean from the atrium the impulses are not being able to go to the ventricles. Okay, so what is sinoatrial block? Sinoatrial block means failure of transmission of impulses from the SA node to the AV node. So it is also called sinus block because SA node is involved, and in this case AV node takes over the pacemaker function, because when in the heart SA node is not being able to transmit in the AV node, it is blocked. So that time AV node should be the pacemaker, right? Otherwise ventricle will not be able to contract. So AV node becomes the pacemaker at that time. So we called it the AV nodal pacemaker dominance is there. So now atrioventricular block. Atrioventricular block means AV node. From the AV node, the impulses are not being transmitted to the ventricles. Okay, it may be incomplete heart block and complete heart block. AV block may be caused by different reasons, like ischemia of the AV node or AV bundle fibers. Okay. Ischemia means less blood circulation. Second, compression of the AV bundle by scarred tissue or by calcified portion of heart. I mean many portion of heart, many myocardial cell or tissue may be scarred due to injury, or maybe calcified due to taking many medication, or maybe different reason, maybe different injury or ischemia. That time it may also called compression to the AV bundle or AV node. Also inflammation of the AV node or AV bundle. extreme stimulation of the heart by vagus nerve. Vagus nerve stimulates the heart very strongly, that time it may also cause atrioventricular block. Incomplete heart block, when conduction between atria and ventricles are slowed but not completely interrupted. It means, just note it down, that here is right atria, here is left atria, and here is right ventricle, here is left ventricle, and from here is AV node, right? Impulse has come to the AV node, it has gone to the ventricle, okay? Impulse has come to the AV node, it has not gone to the ventricles. Again, impulse has come to the AV node, it has gone to the ventricles, but again two missed impulses. So overall, the time is when impulses are coming from the SA node to the AV node, but AV node is not being able to deliver all the impulses to the ventricles. There may be slow or completely interrupted impulses, okay? So this is called incomplete heart block, and in that case it may be first degree, second degree. When first degree block occurs, here PR interval in the ECG becomes very prolonged, okay? PR interval becomes prolonged. We know in the ECG it is P wave and it is PR segment, and then we get QRS complex, right? But this segment is called PR interval, right? This period of time. So this PR interval increases. It may increase like this. So when PR interval is increased in the ECG, we may call it first degree heart block, okay? Because conduction of impulses from the atria to the ventricles is delayed, slowed. I mean, it goes very late. Normally, we know there is AV nodal delay, but despite the AV nodal delay, there is extra period of time that is being required to reach the impulses. So this is called first degree heart block, and in second degree heart block, there may be two types, okay? Mobis type 1 and Mobis type 2. In these two cases, we may get two different scenario in the ECG, okay? There may be missed beat. Let me tell you, in the first case, we are having this is P wave, this is PR segment, this is QRS complex, this is T wave, and again this is P wave, this is P wave, this is PR segment, and here PR segment increases, and again this is QRS complex. But look here, this was PR interval, again this is PR interval, but look, this PR interval was normal, but here PR interval has increased. So this is how PR interval keeps increasing until we just get a missed QRS complex. So let me look here. This was first degree heart block where PR interval was abnormal. PR interval was abnormal, not normal, right? It was normal, but here PR interval is prolonged, I mean increased. But in type 1 second degree heart block, here look, PR interval is of this size, here PR interval is this size, then suddenly we get no QRS complex, I mean we get no such QRS complex. Again PR interval will be normal, again PR interval will increase, again we get no QRS complex. So like this, PR interval lengthens, I mean increases in size progressively until a beat is missed. A beat is missed mean QRST complex missed. We know that QRST complex, this indicates the ventricular depolarization phase. Look into my ECG videos for more updates, for more details, right? To talk about type 2 second degree heart block, here PR interval is normal, PR interval is normal, PR interval is normal, but we suddenly notice that no QRS complex in between. So suddenly no QRS complex will be seen, a beat will be missed, right? I mean drop ventricular beat. When QRS complex is missed, it means dropped or beat is missed. And in complete heart block, what occurs? That complete blockage occurs. I mean there is no impulse going from the atria to the ventricles. So in complete heart block, here is right atrium, right ventricle, left atrium, left ventricle, and here is AV node. So from the AV node, from the right atrium, no impulses come to the ventricle, no impulses. So the impulse going from the atrium to the ventricles is completely blocked. So ventricle contacts on its own by maybe Purkinje fibers or maybe bundle branch. So other junctional tissues apart from SO node and AV node becomes the pacemaker. So this is why heart rate becomes very poor in the ventricles. So heart rate becomes 40 or something like that, not 72 or within 60 to 100. This is the ECG scenario for that reason of the complete heart block or third degree heart block, and it is very, very dangerous. Okay, and the ECG finding is PP interval regular, RR interval regular. RR interval means we know that what is RR interval. This is P wave, this is PR segment, this is QRS complex, this is T wave, this is again P wave, this is QRS complex. So here look, this is R, this is R, so this is called RR interval. Okay, so RR interval is regular, PR interval irregular. Okay, so PR interval will be irregular. This is important here, PR interval will be irregular, and heart rate is extremely low because Purkinje fibers or bundle branches will be the pacemaker, not SO node or AV node. Okay.